Welcome to Straight Outta Health IT. Getting into health tech is rough, but here's an unfiltered dialogue of healthcare leaders and influencers covering a wide variety of issues affecting healthcare and the health tech industry. And now your host, Christopher Cunny.
Again, I'm excited to have our two industry experts on the podcast today, and we look forward to getting their insights on this growing crisis around the opioid epidemic. And before I get their comments and feedback about what's happening, I just wanted to share with our audience some statistics that I found. From 1999 to 2020, there have been more than 564,000 people who have unfortunately died from an overdose involving opioids, including prescription and illicit opioids. The rise in opioid deaths can be outlined really in three major areas and timeframes as well. The first phase began with the increase in prescribing of opioid medications in the 90s, with overdose deaths involving prescription opioids and natural and semi-synthetic opioids such as methadone increasing and has been increasing since 1999. The second wave began in 2010 with a rapid increase of deaths as a result of the use of heroin on the black market. And then finally, this third wave that has recently occurred, and it started around 2013 with a significant increase in overdose deaths involving synthetic opioids, particularly those involving illicitly manufactured drugs such as fentanyl. The market for illicitly manufactured fentanyl continues to change. However, it can be found in a wide combinations of illicit drugs such as heroin, counterfeit pills, cocaine, etc. As well as there are other drugs that are starting to be introduced into the market that are opioid-based as well that continue to affect this population. And it covers all socio-demographic areas as well, too, in our community. With that, I'm very interested in getting the commentary from Dr. Setty about, what's happening in the market today, and what's happening as it relates to chronic pain management and the use of opioids for its treatment. Dr. Setty?
Thanks, Chris, for that great introduction. It's a complicated topic, and I'll try my best to put it all together in a way that makes sense. Of course, it was an easy topic. We probably wouldn't be here talking about it.
Exactly.
We'd already have a solution, right?
Absolutely.
But as you correctly said earlier, opioid prescribing by physicians exploded and created the prescription opioid crisis. We, as a group, I guess it was before my generation, so I can't take all the blame, but the generation before were really pressured by regulators such as the Joint Commission, which regulates physicians and hospitals, who said it's the fifth vital sign and you better get those scores down to zero. Right. There better be no pain or it's going to be a mark against you. Pharma came in here and incentivized people and said, you've got to follow those recommendations. And here's all the tools. And by the way, we'll give you some extra speaking engagements and money to do it and fly you around to be an expert if you prescribe a lot of medications. And then physicians, compelled by all of this and their own incentives, and in some cases, greed, prescribed and overprescribed opioids. And that created kind of that first phase and led to the history lesson that you gave further down the line. Okay. But the nice thing about it is that as much as we were complicit in some of the problem, we can also be part of the solution. That's where my partner and I come in. As we start, I'd like to kind of give you a little bit of basics. People often confuse chronic pain management and the opioid crisis. While linked, they're not completely the same, and I'll try and contrast them.
No, that would be very helpful, because I think I'm a little confused as well.
Yeah, exactly. Thanks. Chronic pain is a state lasting a pain state lasting more than 3 months. Around this time, the nervous system becomes reprogrammed to perceive pain differently. And it may not be something that makes sense physiologically. For example, a feather or a breeze could become intensely painful depending on how your body processes it. This kind of pain is the number one cause of disability and disease burden globally. 20%, about 1 in 5 Americans, 1 in 4 people in the Medicare population have some level of chronic pain. About 10% of them have high impact, meaning it causes severe disability in their life. And most, around 80 to 90%, can't work because of this kind of problem. They tend to be at home. So it has a huge impact and burden on society.
Sure.
There's certain risk factors. Go ahead, Chris.
No, I was saying, sure. Yeah, that's interesting. Mm-hmm.
Yeah. And there's certain risk factors that can make that process worse. We try to measure in our work, for example, which we'll talk about, psychological indices of mood as well as physical activity to understand this better. These things can make things better, or they could make it worse depending on where in the cycle you are. Ultimately, we need to understand all these things and how they fit together in order to improve quality of life. And that's what we try to focus on. So proper pain management of an injury may prevent chronic pain and make it manageable. And that's why it's important for your fellow doctors to make good prescribing decisions and for you to follow their advice. And our service can be a very useful one in the process. So while also complex, I'll try to avoid oversimplification, but I want to explain the next part of it, and that's addiction. When medications are used in ways that are not intended for behavioral health or kind of that high that we often talk about, this can lead to dependence and behaviors of addiction. So when people are in proper pain management and follow their doctor's directions, it's unlikely that they would go down that road. Right. But if they start to get their medicines off the street, if they start to do it for a high or a good feeling, then it's not part of pain management. It starts to take you down that other road. And part of what we try to do is identify those risk factors and keep people from going down that road. So when pain management's not done properly, it's possible it can lead to bad pain management behaviors that lead to addiction. Examples could be taking untreated, unused pain medication, like from a cabinet, maybe your dad or your wife's unused prescription in order to get high. It could be buying it on the street. There are some populations that are more vulnerable because we don't want to treat their pain properly. Right. As you might guess, those who live in poverty or suffer some racial bias. So there are some links between pain and addiction. But generally speaking, if you see a physician, you follow their directions, and you do things as prescribed, you're not going to have an addiction. So that's one thing I like to make clear. Proper pain management prevents addiction. Even taking opioids under the care of a physician and following their directions can prevent addiction. So pain management, when done properly, can actually prevent a lot of the harms that you were describing.
No, that's great. That's very enlightening. I think we sometimes forget that, these drugs have a positive impact. If, to your point, managed properly, it's when we abuse them and, take advantage of them, then when they can become very detrimental to our health. So thanks for the explanation. That was very enlightening. I know for me, I'm sure for others as well. That's great. Bryan, why don't you share a little bit of your background and give us your view on how you got together?
Sure. Started, I kind of always wanted to be an anesthesiologist and pain medicine physician. I had a family friend growing up who was one, and it kind of culminated in me going to medical school and eventually where I am now at Johns Hopkins Hospital in anesthesia and pain medicine. But along the way, I had mentors who created digital health products as well as medical devices, and they were mentors and worked closely with them. One was Thomas Errico when I was at NYU, who has patented and prolifically and developed medical devices for spine surgery. Watching that process and doing research in his lab led me to wanting to, use my skills and what I had, at my disposal of being able to prototype and invent and patent and do software development myself. And, my desire to be both a physician and a patient advocate to, kind of navigate this very complex healthcare transformation that is, occurring right now. And as Amar alluded to, we first met in an advocacy group for anesthesia in Maryland, and found that we both had similar interests, backgrounds, and desires to help others through innovation and entrepreneurship. And that culminated in the formation of Patient Premier and ultimately our principal product, Pain Scored.
That's great. I do want to delve into a little more detail about Patient Premier later in the program, but I did want to get your insights on a few other topics around this issue of the opioid epidemic. Local communities are increasingly called upon to address this crisis, which involves interventions across the continuum of care, whether it's prevention, harm reduction, or treatment or recovery. These programs are aimed at preventing new cases of opioid use disorder, or OUD, trying to identify those early cases of opioid misuse, ensuring the effective treatment and employing harm reduction strategies and support of the vulnerable populations. I'm just curious, how can, communities begin to prevent opioid addictions and overdose deaths by improving the lives of those struggling with OUD, by addressing social determinants of health, disparities related to OUDs, especially in the area of COVID-19? What are some of the focuses I know some communities are working on are things like employment and housing and education, but from your perspective, what can these communities do to address the challenges that hit these most vulnerable communities the hardest when it comes to the opioid use disorder? And I'll start with you, Bryan.
Yes. So I think it's a multifaceted problem and certainly has not been solved, as the COVID epidemic had shown, greatly worsened this problem. So we definitely don't have a handle on it by any means, and overdose deaths starting to creep back up. There's a kind of a myriad of approaches to the problem, and it kind of centers around resources that are provided to the community when you can identify substance abuse and you have somebody who is willing to stop. That's pathway for some substance abuse programs, and we have things like methadone clinics that can help wean people off when they've found illicit substances to replace pharmaceuticals, or if they were just on illicit substances to begin with. But that process is just one of the many different aspects of the opioid crisis. And
Sure.
It doesn't have to be methadone, it can also be buprenorphine. So one of the largest things right now is trying to get providers waivers to write for a medicine that doesn't hold as much stigma as perhaps a methadone clinic, that you can be prescribed buprenorphine to kind of help you come off of the opioids that you are addicted to. And that's, one kind of avenue is to expand alternative therapies, get more people enrolled in those prescribing of those therapies. But that's just when you've recognized the problem. And
Right.
the whole other end is when you've not recognized the problem, and it goes into, as you alluded to, employment status, mental health, social support. And that's a very challenging things to try to target resources to, but there are, mechanisms to do so. And that's a little bit more of a gray area. Whereas, once it's a recognized problem, it's something that, can be, targeted. But I'll turn it over to Amar for his thoughts as well.
Sure. Amar, what's your thoughts on this subject?
Yeah, in the beginning, I'd like to make one very important point, is to avoid conflating the opioid epidemic with pain management. They're two separate topics, really, and conceptually, at least, it helps to think about it that way. Pain management, when done effectively, can involve pain medications like opioids, or they may not involve opioids. They may involve interventional pain medicines. And this is related to pain that exists for long periods of time. What I want to make sure people understand is that taking pain medicine does not mean that you're going to become addicted. When done properly in a monitored manner by following the instructions and avoiding diversion or pills being taken by someone who wasn't prescribed the medication, you can do everything very safely and effectively. Now, there's certain populations that are more high risk. And if you can identify those people ahead of time, you can more easily target resources so that effective pain management does not lead to bad behaviors in the future. So as long as you follow your doctor's orders, you are generally very safe. The other side of the coin is the opioid epidemic that we've been talking about. And that involves people who either because they're denied effective pain medicine, and there's some factors within our medical system that keep people from getting effective pain medicine that may divert them to an environment where they're not getting, where they're getting it off the street, or because they're using that medicine to achieve a behavioral effect. That feeling of being high, that can lead to the opioid crisis as well. So I like to, in the beginning, make sure that we separate the two concepts.
Exactly. And let me stop you there. What are some of those factors that, impact the use of, these drugs as well, too, or the lack thereof, or appropriate administering of those drugs?
Yeah. In our country, we definitely have a bias for socioeconomic reasons to avoid prescribing medications for people we perceive who are, for various reasons going to be more likely to abuse those medications. Those things aren't necessarily true, but there's a perception among a lot of healthcare providers that they will undertreat pain in these vulnerable groups, typically people of lower socioeconomic status who are racially more likely to be colored. They tend to undertreat, and that tends to lead to a number of patients being forced to go outside the system. Not everyone, this is still a small percentage, but that ends up leading to people who leave pain management and end up going into becoming victims of the opioid crisis. And then outside of that, you have people who, for various risk factors, such as maybe anxiety, maybe depression, all of which we know poorly treated in the current system. Mental health is very poorly addressed by the current healthcare system, may end up going to the street to self-treat either with medications or alcohol that they shouldn't be. And then that can lead to further progression down the line. So the idea here is that effective pain management, when delivered across the board to all people equally, can really help influence and avoid a lot of the problems with the opioid crisis. Not all of them, but many of the problems. Bryan, anything you want to add there?
Yeah, two things. One is that we did hit on a lot of the risk factors. You said poverty, unemployment, and kind of this personal history or family history of substance abuse. And it's also some behavioral things, such as people who take on more risk than others are more likely to have addictive tendencies. And this is some hand waving here, but it has been studied, and there are screening and assessments that can provide some light into, we know these risk factors. And then if you have a patient to take an assessment or someone take an assessment, you can actually, have a better idea of their risk for this misuse.
So that sounds good. I'm curious, obviously, part of the reason why the two of you came together to start this company was to try to close the gap in this area through the use of technology. And so I'm just curious, I'm sure audiences as well too. One, how is technology now being leveraged to help address, the opioid use disorder, to help close the disparity gap around pain management, and just in general, reduce the likelihood of individuals becoming addicted to these substances?
Yeah, I think that, first, there's kind of a misnomer that people believe that perhaps pain is just purely subjective and there's not an objective measure. But that's not true. Similarly, as I alluded to, one could assess for the risk of misuse of substances due to known risk factors. You could also assess for pain, and there's measures that you can discuss with patients in the form of an assessment to understand their level of pain, disability, and the impact on their well-being, mental well-being, as well as functional status, et cetera. And those metrics are able to be digitized, tracked, and trended, and those allow themselves to be placed in a digital platform. Whereas if you took the kind of approach I discussed earlier, where you thought, pain is purely just subjective, it's just however you're feeling. There's no painometer that you can strap to somebody. It's not like a heart rate monitor where I know your heart rate by just directly monitoring it. I don't have a painometer that I can get your pain level without asking you. It's not exactly that subjective. It's actually fairly more objective, and then lends itself to digital platforms to help patients, providers, insurers, et cetera, make sense of what is perceived to be a subjective experience.
Exactly. Amar, did you have anything else you want to add to that?
Yeah, thanks, Chris. I think one of the big things that we've been able to do is take something that's highly subjective and quantify it so that we can track it, measure it, and see how patients are doing over a long period of time. And that's something that's been lacking in the current system. That level of subjectivity led to variations in care, so that physicians were doing one thing for one patient totally different for a similar patient in the same clinic, or physicians in one part of the country doing things very differently than others. And that's different than, say, what you might see for blood pressure or other disease states. And if we can help standardize the process by objectively measuring something that's difficult to measure, we can bring a lot of clarity to a subject that's very hard to clarify and understand. And that's kind of our initial approach at all of this is, let's make this easier to track, trend, and follow. And that's where data-driven approaches and technology help so much.
Well, that actually leads us into learning more about Patient Premier and what you guys are doing through the use of technology to help us, again, address this issue. So maybe, Amar, you could take a few minutes, and Bryan, please jump in as well, too, and share with us, what is Patient Premier, and how is it now being used to help manage the challenges associated with the opioid addiction crisis?
So Patient Premier at its heart is really a data analytics company. We developed algorithms, basically computer learning tools, to help take complex data and reduce it into information that physicians and patients can use to better understand how patients are doing and improve their care and communication. What we were able to do in our early phases is to find a way to document this information so that physicians can actually use it as part of care management. This is a remote concept in which patients are monitored remotely, and we're able to see how they're doing in their real lives. We add a layer on top of that where we call patients and help them log in, use the system, ask them questions, and find out whether they're following their treatment plans. All of this is used at the end of the month to document better for the physicians, have better interactions with their patients, and also to get some level of reimbursement or payment from insurance companies, which is a win-win-win across the board. As we evolve, what we're doing is we're taking this data and helping insurance companies and payers find out how to best pay for things, how to pay for things without making it a struggle for patients and providers. In other words, if the data supports it, let's get it approved and not have to wait for all these hurdles for physicians and patients to jump through. I can't tell you how many times I hear about how frustrating it is for patients to have to deal with insurance companies. And the better we can create processes to allow the data to make that automatic, I think the better off everyone will be. So that's how we're looking to provide value to the system as a whole. Both in the current reimbursement model and in the future, what we call value-based care model of care. Bryan, anything you want to add there?
Yeah, and I think that, it started just with a simple premise that, the current standard of care was guesswork. You didn't really know exactly how a patient was doing in between office visits at home after a new medication or procedure was performed. Sure, you can ask them when you saw them next after 90 days and, ask them, but, that wasn't a very effective, method, and is, kind of suffers from, medications and, procedures or something that have to be done continuously, can wax and wane in its, kind of effectiveness. And this is very challenging. You have people who are unable to recall, how they were several weeks ago. You have, dynamic changes, such as, just the patient may have had to travel an hour to come see you, and when they drive in the car, it hurts them. And things like that make it, hard to understand how someone is doing at home in between office visits. And, our, kind of principal solution here in our beachhead market in the pain medicine space was to demystify that, quantify it, take the guesswork out of it, and then through that measuring, learn. And that's what we're doing right now is we're learning. We are learning, how to empower patients. We're learning how to make providers have better decision-making surrounding clinical care, and how payers can have better data such that they can, as Amar alluded to, make sure that patients are getting high-quality, fast care without hang-ups. Right now what's going on is if somebody wants a shot or an injection or any new medication, they go to their pharmacy after the order is put in, and they usually get hit with a prior auth, and the doctor has to fill it out. It might take a long time to get approved, and the patient goes without their medication. And same thing for the procedure. Want to, make that a little bit more streamlined. We believe that we can kind of just use this health data with just integrity and purpose, and kind of clean this up for patients, providers, and payers.
And where do you see the future of this type of technology going to improve the treatment of patients in this space as well? It sounds like you've got a rich repository of information that's being leveraged today by payers and some providers. But I can see also how this data could be used in research, in education, and other ways of making clinicians smarter about and more aware of the better treatment protocols in this space, more sensitive to the different, ethnic groups that they're dealing with, and, holding them, quite honestly, accountable too, in some degree. Yeah. Around how they're treating the different disparate groups that are under their care. Just curious from your perspective, what are some of the use cases, not only that you see today, but that you can foresee in the future that a technology like this will be able to support?
So, Chris, everything you said is 100% spot on. I think we need to hire you to work for us. And let's talk about some of those disparities in chronic pain right now, because
Sure.
I think they're somewhat telling. It's about 65% of adults over 65 have some level of chronic pain. When we say chronic pain, this is pain that lasts more than 3 months.
Right.
When it lasts that long, it starts to reprogram your nervous system, your nerves to your spinal cord to your brain, the connections within your brain. And there's certain things that affect that, like anxiety and depression, being physically unable to get up and move. All these things make it worse. And if we can unwind these processes, we can make things better. So we know it's highly prevalent. A lot of people have it. We also know that it's worse and it's more likely to be a problem in people with lower socioeconomic status, if they have less income, if they are Hispanic, if they're African American. There's a perception that not only do they have higher levels of pain, there's a perception that they're going to not use or participate in treatment better, so they tend not to be treated right. So by using our data-driven approach, we can look at all of these patients in a continuum and see if providers are treating everyone equally, treating everyone with the correct treatment, and whether their results are progressing in the right manner that they should be. Because right now it's so subjective. We have no idea if my variation in care for one type of patient versus another is a reflection of me or a reflection of the patient. I want to be able to say over long periods of time, because it does take time to figure these things out, are we treating patients across the board of all socioeconomic statuses, of all races, genders? Are we treating them well? Exactly. And that's something we'd love to be able to answer for the system of a whole. Our long-term evolution is to really be the quote API, the common core platform for pain, so that everyone, every EMR, whether it's Epic or Cerner that you might be on, every RPM, remote patient monitoring company you work with, every clinic that you're in, everyone uses a service, either ours or something like ours, to be able to analyze that data, get additional data when needed, and identify whether there are gaps in care and inconsistencies in care that are causing harm.
That sounds great. Bryan, any additional thoughts?
Yeah, I think that, the learning component is, what's so exciting is that, what we had prior was something that was unmeasured and guesswork. Now you're having something that is now measured at home where it wasn't. And through that, we're able to find things that are both, just not intuitive and often counterintuitive to help everybody, patients, providers, et cetera. And those are the kind of medical problems that we have now. The problems facing the system, including the opioid epidemic, these are not easy problems, and they're counterintuitive. What you would think might solve the problem worsens the problem. And the only way to cut through it is with objectionable data, trials, new products and services. And that's where we're at, and that's what we're most excited about. As Amar alluded to, we might not have a painometer that will strap to somebody and it'll tell you exactly what their pain is and, objectify it. But it will be something, along the lines of, the more that we know, the better that we can predict and understand not only, kind of what is most likely to help, but would be, just the best thing to do at any given time.
That's great. I want to commit. I'm sorry.
I was going to say, Bryan, you said objectionable data. I think you meant objective data.
Yes.
Exactly. Maybe objectionable to some people, depending on the results. But to your point well taken. I do want to thank both of you for the work that you're doing in this space that is so needed right now. This is a topic that's in many cases misunderstood. There's not enough research and knowledge done on it, and I think the work that you're doing is going to have lasting and long-reaching effects in this part of the delivery of care. So I want to thank you for your efforts here, and I look forward to hearing more about Patient Premier and the impact that you're making on the opioid crisis as a whole. We've got 1 minute left to offer kind of some final thoughts. And both of you are doctors, and now you're entrepreneurs and technology junkies. I'm just curious, is there any words of wisdom you would give, other aspiring doctors who have a great idea and they feel like technology can help to address this issue that you would share with them? And I'll give you each of you 30 seconds to make a comment.
Yeah, the main thing I'd say is it's a long road. Don't give up. Don't be afraid to change if the data suggests that you should change. And part of it is a real regimented way of finding the right business model for a great idea. Not all great ideas have a great business model behind them. So you got to combine the two to really come up with what you ultimately turn into a great company.
Bryan?
I think that you have to have just the utmost resilience and perseverance. It has to be something that you just feel like, drives you every day to actually see that mission and fulfill that. And at the same time, it's almost like something like investing. You can put a small amount of money away every single week. It might not seem like a lot, but over a decade, it turns into something great. And that's very true here for entrepreneurship.
Well, great advice. Again, thank you, Dr. Amar Setty and Dr. Bryan Marascalchi, correct?
Yes.
Thank you both, co-founders of an amazing company, Patient Premier. We look forward again to hearing continued success in your endeavors. I will love to have you back to continue this conversation and get an update on how things are progressing with your company. Thank you all for taking time out your busy schedule to listen to another episode of Straight Outta Health IT. As usual, we appreciate your comments, feedback, and ideas about topics we can cover on this program. Let's make this episode go viral. You can find us on all the major podcast platforms, Apple, Spotify, Google, you name it, we're there. Love to have you as a continued supporter. Tell your friends, family, and loved ones that we're here, and I'll see you next time on Straight Outta Health IT.
Thank you so much for listening to Straight Outta Health IT. We hope you enjoyed today's guest. For more unfiltered dialogue of healthcare leaders and influencers, be sure to tune in next week. For the show notes, transcripts, and resources, please visit Apple Podcasts, Spotify, or your favorite streaming platform. We invite you to give us feedback by reaching out to Christopher Cunny on LinkedIn, just searching for Straight Outta Health IT, and you'll find us. We are constantly having live discussions about diverse topics in the industry.